So this was all for pediatrics, right?
I got the axe, right?
Yeah, oh, I need some axe spray. That would be helpful. So if anyone has that. So you can just be reminded of those teenage years and all those things that were super fun about being a teenager. That you're welcome to my teenage locker room. So this was all for you. But this just means that this is our last one, best one. Today's the last day and even another class down. So I'm so excited. You guys have just been the best class. Let's see. Let's ask just a couple questions. How old at what age would you say, I need to refer this child for an umbilical hernia to a surgeon? 5. Why do you get a lipase amylase for intestinal atresia? Check if the pancreas is involved. How is the pancreas usually involved? Yeah, what's this? Yep, what's this? What's the word? Annular pancreas, yes. Which one is associated that it is inside the umbilicus? The gastroschisis or the omphalocele? Omphalocele, perfect. Where is your Meckel's diverticulum located anatomically? 2. Yes. I love it. I love you guys on 2. 2. Yes. What is your indication to do a DRE in infants for diagnostic clarity? Hirschsprung's disease, yes. Does human milk help or hurt necrotizing enterocolitis? Why does it hurt? So that's a trick question. It helps prevent, but if you actually have neck, you want to stop the feeds. That was a mean question. Such a mean question. I won't do that to you on your testing notes. Current jelly stool. What's the word association? Interoception. Perfect. Yes. Okay. We are finishing this up. Please, nobody pass out on me. Doesn't look well if that happens. So, again, a quick reminder, finishing up EM, a few things that are different with PEDS, or a couple of reminders, and then ortho for this. So, poisoning, a huge issue with children. Why? They just want to eat everything, right? So they're just shoving things in their mouth. Male is going to be more common, and then it switches in adolescence to females. Why? Yeah, females are going to be doing this intentionally. So males are just like, this marble looks cool, I'm going to eat that. The females then are going to say, I want to end my life, so this is going to be really intentional. A lot of common products, so things that are left out, they're going to be the things that they ingest. I spent a week in residency in the toxicology and the poison control center. Fascinating, the things that people call in for all the time, and the answer over and over was, this is totally benign. They'd be like, my child ate a whole tube of toothpaste. And they'd be like, totally benign. Like, my child ate the little things inside a box of shoes. Totally fine. Even though it has like the skull and crossbones on it, you'd be like, what? So, all of that to say, I would encourage you, because there's toxicologists there, physicians there, there's a PA there, nurse practitioner, all kinds of people there. If you ever have a question, call them. They're super helpful. Even call them from the ER. They're great. Such a great resource. So burn centers, really nice. Toxicology, poison control, also really nice. One thing about this that your textbook that I don't love it is that it calls it unintentional ingestions in young children. If you've ever been around a child, it's very intentional. They did not intend the harm that came from that, but it was intentional, right? So that's what they're really saying, is this child intended to put this in their mouth. They didn't intend for the outcome from that. So what are the ones that we actually are really worried about? Well, the ones that cause significant issues, the ones that cause cardiovascular compromise and altered mental status, any kind of seizure, and down. So the history of what did they take, how much, when, do you know what it was, did they take anything else with this, is going to be super helpful, and then obviously their physical exam for any kind of differentiating sign with that. You will sometimes have some diagnostic studies. You can sometimes say, I want to see exactly how much Tylenol, for example, they have in their system, versus I don't know, we're just going to have to see what their electrolytes do, what their acid-base balance does with ABG. what we have going on, continue to monitor. So those are your two options. When I was going through school and into residency, we did a whole lot of activated charcoal, and it was icky. Has anyone used activated charcoal here? It's truly activated charcoal, and it's this real sticky, tarry, black substance that you're trying to get this child to drink or shove it down with an NG tube. It's a disaster. And really, if you're looking at it, you can't use it for caustic or corrosive agents. You can't use it for any of your heavy metals. You can't use it for your water-soluble compounds. So you're like, what am I really using this for? And that's really what some of the answer is we don't use it that much anymore. So if you have carbamazepine, dapsone, phenobarbital, or theophylline, knock yourself out. I'm not sure that I've seen a child use that in a really long time. So activated charcoal is probably not going to be the answer for most things unless you see a specific drug that you know is associated with that. You can use sodium bicarb to alkalinize the urine. So if you have an acid-base issue like that, so salicylates or methotrexate can be used for that. And then certainly if you are like, we have to get this out, this is killing the kidneys, or there's no other way to do this, dialysis is always an option for these kids. Big takeaways. Do not pump the stomach, gastric lavage. We're not pumping stomachs of people. We're not using syrup of ipecac. It's an old thing that used to be to induce vomiting, and so people will literally, you can't sell it, you can't get it anymore. It's amazing what comes off the shelves. Somebody's great-grandma will be like, I have this bottle of syrup of ipecac, and you're like, where did this come from? So, moral of the story, you're not going to be giving that, but some questions to ask to make sure. They said, we tried to pump the stomach, we tried to make them vomit. Those are things that are out there in that kid land. Certainly, worst case scenario is that you end up with a coma, you end up at a toxicity level for this. Any kind of aspiration, so they tried to ingest it, and then they ended up trying to breathe it in. That's a pretty bad scenario too. And then a reminder from way back in freshman semester of like some of your things that are going to be causing your metabolic acidosis or your mud pile. So a little bit less common in kids, but things to be aware of. Any of your compounds that were going to cause an electrolyte disturbance that will cause a dysrhythmia can be there as well. Certainly GI issues are a huge thing, or hepatotoxicity for several of these compounds, and then some seizures. Moral of the story is that most of these poisonings have minimal to no toxicity, and being aware of what does is going to be where you will be spending your time. Most of them under 12, it is unintentional. They do not need any kind of acute care for that. The ones that I have seen are the ones that end up drinking things. So for instance, under the sink, one of the worst ones, the child somehow was able to get into bleach, and they ended up just drinking bleach. So that is the child that we're trying to prevent from that. So anticipatory guidance and safety, those are the things that children will get into. Adolescents, totally different ballgame. Most of those are intentional, and they will need inpatient. It is then more oftentimes for the site component than the compound, certainly depending on what the compound is. So what I would spend your time on more is making sure that you have these specific ones that we're going to talk about down versus kind of a more general concept that is more in the ER realm. So narcotics. Okay, is that going to slow things down or speed things up? Yep, we're going to slow things down. So pinpoint pupils, respiratory depression is really what we're worried about. So if you are breathing 4 times a minute, what is your CO2 doing? Rising. Does that make you more sleepy, less sleepy? More sleepy, right? Then you start breathing less, and so you do this less and less and less until now you no longer breathe. So that is what our concern is. Then Narcan is the thing to give, and it is very, very safe to give. So that would be another one. When in doubt, check with glucose, and then go ahead and give Narcan. There's very few side effects in this, and it might help. So if you have a child that is with truly lethargic, truly just out of it, you don't know why, their glucose is okay, very safe to go ahead and give a dose of Narcan to see if there is any improvement from that. If you're like, should I get it 1 ampule, 2 ampules? You can always start with 1, certainly if they're less than 1, but okay to titrate to effect as needed. Do you remember this is a short half-life? So this will often be if they have taken something, you give them Narcan, they come back, and then they start to go back down. So you have, oh, I have to give it again, and then they go back down, depending on how much they took. So just a reminder that Narcan has a much shorter half-life than what they took most likely. Iron. Start this one. This one's one that I get very concerned about because kids love to take things with iron. So for a fatal dose, it can be as little as 10 tabs of whatever they're taking. 10 iron supplements, 10 prenatal vitamins can be toxic to a young child. So it doesn't take a whole lot of iron to be able to do that. The other problem with this is that this is one of those ones that we can't use activated charcoal for. So small toxicity dose, difficult to get out of their system, and readily available because we have a lot of people on prenatals or some kind of multivitamin supplement, something of that nature. This was one of the reasons, if you look on the back of your gummy vitamins that you take, does anyone else besides me take the gummy vitamins for adults? If you look on the back of gummy vitamins, most of them don't have iron in them because gummies are going to be the ones that the kids want to eat. So if they're said, let's just make it 1 step harder. So if you are trying to get those gains in the gym, and you're really trying to make sure that you have that extra iron, it's probably not in your gummy vitamins. So something to think about. For these children, let's say they did get a hold of all of this. The first thing, it's going to be in that GI system. So it starts relatively soon after their ingestion. They have some GI upset. Then there's a kind of a eye of the storm. And that's how Fe iron, right? The eye of the storm is that it's bad, it's good again and then it's bad, and then they end up in severe acidosis, GI issues, coagulopathies. So bad, good, bad. Your deferoxamine is going to be what you will use then. Remember, it has Fe in it, so deferoxamine for that. You can give it in a multiple amount of ways, depending on what kind of access you have and what kind of availability you have. These kids usually will go into the PICU with us if they need it for supportive care, dialysis, depending on how much they took, and then any kind of exchange transfusion. Did I tell you guys about exchange transfusions in NICU? Where they literally have 2 syringes, so you have a kiddo hooked up, and you have one side literally pulling out blood, while the other side has a large syringe and is pushing in blood. So you're literally exchanging blood real time. So pretty cool. Tylenol poisoning. Tylenol, acetaminophen. So this one is another one where oftentimes intentional. If you are in that adolescent age, oftentimes unintentional. If you have Tylenol laying around and you have a young kid who gets into this. So again, those GI symptoms are going to be first. Then they start to look and feel better, and then the hepatotoxic dose is what really takes over. So this is a very sad one because a lot of times they take this, especially for the teenagers, they ingest it, they take it, they start feeling terrible, then they end up feeling better and they're like, why did I do this? I didn't want to do this. I actually don't want to die. I have a new lease on life. And then the hepatotoxicity starts. So very, very sad if it is a true intentional ingestion in any ways, because it can result in this hepatoencephalopathy, coma, and or. Good thing there's an antidote. Do you guys remember what the antidote is? NAC. What does NAC stand for? N-acetylcysteine. Interesting though, so the things that you are going to do, if you are the primary care PA, you are the PA in the ER. First thing you are going to do is get a level. Do you know how many hours you are going to get that level at? 4. Yes, and so that is one of the board questions that I have seen come up, is that they try to get you to get that level at a different time frame. So they'll say a random acetaminophen level or some other time. So it's a 4-hour level, and then you'll plot that. Where are we? Are we above the threshold for hepatotoxicity or not? If you have determined we're going to give N-acetylcysteine, you have committed that patient to 17 more doses and the entire stay in the ICU. Okay? So when you say it's a go, you've bought them that whole time. So you want to make sure that you have the appropriate 4-hour level and that really you're saying this is a go because they're going to be staying with you for several days in the ICU at that point. So, entire course. Lead poisoning, a lot less acute than some. Most of the time, it is a slow ingestion of this over time. Okay, what's that classic thing that we've all seen as our young adults? Who were the kids that got lead poisoning? Yep. And so we see this, they're slowly over time, they end up with, the thing that you will typically see on labs is a microcytic anemia. So we say, it's going to be iron, it's going to be iron. Oh, wait, it's not iron, it's lead instead of iron. So another heavy metal that you see with that. And you do see this in the lead lines on x-ray as well for that too. So certainly you're going to be getting a lead level and seeing if that is too high. You're treating your two are EDTA and dimercaprol for trying to get these. Subsmart guesses of them. Seeing lead lines on x-ray, so that extra deposit of this. So certainly, again, not as acute as if you were talking about iron, acetaminophen, narcotics, something opioids, but something that you do see sometimes. Carbon monoxide poisoning, we talked about this one yesterday. So this one, the boards love this one. This can be a pretty dangerous one because if you are in an environment with a whole bunch of people and now, instead of carbon dioxide, you are carbon monoxide in the room. This carbon monoxide can go and replace that, that oxygen molecule, which results in what type of shock? Dissociative shock, yes. So it results in a dissociative shock. They end up, again, they all come in. So if you see somebody and you're like, this is some sort of flu, and then they say, my entire barrack, my entire, on board to best I've seen, college dorm, my entire house came in. The other way I've seen this is they'll say, there was a cold front in Texas out of nowhere, and they brought in the kerosene lamp or something, like some sort of indoor heater that is not normally there, and that can end up increasing those carbon monoxide levels. So a cluster of people that all have this cherry flushed face and a flu-like illness that you are going to treat. So you have to almost flush it out, so you flush that out with 100% oxygen and a hyperbaric chamber if needed. Nicotine poisoning. So at first we weren't including this one. We were thinking like, which kind of kids are gonna chew on cigarettes, right? I mean, they'll chew on anything, so sure. But we started seeing this more as vaping kind of took over because the pods are sweet. And so the kids are getting a hold of this and they are ingesting too much nicotine associated with vaping. So it will result in a sludge type symptom. So they're tachycardic and then just drippy. So everything, if you're thinking about that, they are drippy, that kind of sludge. Can end up, depends on how much, CNS depression, some paralysis that you will see sometimes. And certainly, I've never seen this, but if you had so much, it could result in coma death. Supportive treatment, if you need to, too much parasympathetic or that kind of drippy, everything is in that parasympathetic state, reverse that with some atropine. In general, again, your poison control are the most wonderful people. Toxicologists they love what they do and they are really good at what they do. So I need everyone, because everyone here is going to be a provider very, very shortly, to pull out your cell phones right now. Take your cell phone out and put poison control in your phone right now. So the number, 1-800-222-1222, right? So we are not the 444 people, we are 222. 1-800-222-1222. Okay? So this is literally in my appointments what I will have parents do, because the worst thing when you have a child who has ingested something is you're like, I don't know, who do we call? We should call grandma. My mom, your mom. I don't know, we should call somebody. Do we call their doctor? Who should we call? And they don't know what to do at that moment. They're trying to Google poison control. So I have them put it in their phone right then. This way, I'm going to ask you to remember it. But this way, you can just have it, pull it out, make sure for these families you say, put it in your phone right now, 1-800-222-1222. And then it's in your phone too, for when you're on rotations and somebody happens and we're like, we should call poison control. And they're like, got it. Okay, Switching topics, foreign body ingestions. What is the difference between an aspiration and an ingestion? One's into the lungs, which one is that? Aspiration. And then, so this one's ingestion. So which tube is this going down? Esophagus. Yes, exactly. Did I tell you the story of prom? Kid in prom? Yep. So he was to the corsage. So he ended up sucking down the corsage pin. So that was what the concern was. Did he aspirate that, or did he ingest that? Ended up that he ingested it, and so he got to stay with us until the pin made its way all the way through. Coins are going to be most common. Don't know why children love it. I suppose they see round, shiny object and think that I must eat right now. So that is what they do. Coins, we see it all the time. So anything that's going to be small or round. So foods that what are going to be some of those common foods? Grapes. Yep, any kind of berries, peanuts, cherry tomatoes, anything, hot dogs. So ideally, you're encouraging parents to cut it into a shape that's not going to perfectly lodge in an esophagus or a trachea. So anywhere they drink. Things that would put them more at risk if you already had some sort of dysmotility. So if you knew that this child had a TE fistula and had the esophagus anastomose together, and they are at risk for that stricture right there, well maybe we want to continue to make sure that they don't have that type of round foods, or that they are not being exposed to that for even longer than you would for most toddlers. If you had other kind of esophageal pathology and eosinophilic esophagitis, pathologic GERD, things that will happen, oftentimes they will be drooling. If they can't swallow it, it has to come out the top. They might not want any kind of food, and they might say something about their chest hurting. So most of the time, you're not seeing any respiratory symptoms because, again, for ingestion, not the trachea. Yes, you want to do an x-ray to make sure you know which one is it in, trachea or esophagus. And you will be able to see some of these not. The best x-ray I ever saw, which was the worst x-ray, this child had somehow, I don't even know how, pulled themselves up on a Christmas tree, got an ornament off the Christmas tree, swallowed it, and it was a perfect snowflake. You could see right on x-ray. You could see exactly where it was, and we watched this snowflake go on down. The snow was falling. If you can see this, sometimes an endoscopy, so they waited till it was in the stomach, got an endoscopy, pulled the snowflake out. Things that you must remove then. So a lot of times we'll just let it fly, right? A big Christmas tree ornament, that was a little too big. A lot of coins, Legos, all of those things, you're like, we'll see you on the other end. But the ones that absolutely have to come out. So if your child is symptomatic in front of you, so clearly if they're having an acute response, acute gastritis, certainly that needs to come out. If there are multiple magnets, so if they have swallowed multiple things, you're worried that the magnets in them are going to find each other and perforate internally. So multiple magnets, you need to take those out. And then any kind of a disc battery or button battery, why that? Yeah, it can corrode right through. So you're worried that they're going to perforate even if there is just that one. So disc batteries, multiple magnets, and then anytime that they're symptomatic. Those ones need to have an endoscopy to have that removed right away. The rest of them, like I said, sorry keychain, sorry Legos, sorry coins. We'll see you on the other side. So you should be able to see the button battery. If you can't, then those are the ones that we kept for observation, and we watched them to see if they became symptomatic. And then that was a consult directly to GI, because there were sometimes it was like, we don't know what they swallowed, and then they were taken for a scope. Overall clinical picture. Okay, a little bit on urticaria, angioedema, and anaphylaxis. So urticaria is the fancy doctor's PA term for hives. So now they'll come in, and your patients will say, I have hives, and you're like, I will diagnose you with urticaria. Your fancy words can be your new diagnosis there. But really what is happening is, remember I talked about, there are so many immune cells in your skin. So this is a true immune response in that epidermal layer. So all of your prostaglandins and cytokines are released from mast cells, degranulate, and it is usually then IgE mediated, which means this is a true allergic response. This is itchy, this will migrate all over them, and you will see this in all kinds of things. Acute urticaria or chronic urticaria is going to be one of the things that just drives people nuts, and they will spend so much time trying to be like, what is this thing that is causing me hives? They will drive themselves crazy, and most of the time, something has set off these immune cells in your skin, and you have no idea why. So certainly, if you're like, wow, I really got into the poison oak or whatever, you know exactly what's causing that reaction and the secondary hives of that, sure. If you don't know though, people will drive themselves crazy. They're like, it's my laundry detergent, it's the fabric softener, it's the lotion, it's the bath, it's the salt, it's the water. And they will go nuts, driving themselves crazy with that. And most of the time, it is nothing. It is a virus that caused something to trip off. It is something in their own immune system. It is nothing that they can do. And your job then, as the primary care PA, is to try to walk them off that cliff of you didn't do anything. Let's help treat your symptoms for that. Urticaria looks like hives. It is hives. That raised wheal and flare you see can be in one spot, can be all over their body. Angioedema, now this is the same thing, except now it is even lower. So it's not just the epidermis, now you are down into that dermal layer. Same activation, same cytokines, same response, just top layer, now bottom layer. Again, IgE mediated, and the face is a very sensitive spot to this. So facial angioedema usually goes with this. Again, 6 weeks is kind of your cutoff to say this is an acute process or this is a chronic process. At that 6-week mark, your body and their bodies have kind of formed a well-worn path of this is just kind of what we do, and so now you are in that chronic state. So you're managing it a little bit differently. Please don't spend time memorizing this chart, but the point of this chart is to show you what things are causing hives. If you look at it, you could just sum this up and say life, right? So if you're looking, you're like, all these medications, sure, any kind of virus, sure, grass, animals, dander, bites, eggs, wheat, milk, soy, cold, heat, sunlight, exercise, stress, anxiety. So you're like, anything can cause this, not the thing that we need to chase. The symptoms are often what you are trying to help manage, right? So that's what I usually tell families. Life can cause hives. That's okay. So obviously if it's something specific, if you're like, wow, you are taking a new ACE inhibitor and you have angioedema, well that's a pretty well-known one. Let's stop your ACE inhibitors. Super well-known. If you have a 7-year-old that's in my world, it's just an itchy little sucker, it's probably not going to be something that you are going to find, and the symptoms are what you're going to manage. So yes, first thing, avoid the triggers. That's always your answer on any board. It is lifestyle modification, prevention, education, airway management. So those are always going to be first. Next, the thing to know is a lot of reassurance. Most cases will resolve spontaneously on their own. The next thing is your symptomatic relief. So this is the time where you are really doing antihistamines because what is released from your mast cells? Histamine, right? So antihistamine. So this is a little different when we talked about allergic rhinitis, where the inflammatory response is the problem, and we're using those intranasal steroids. In this case, it's truly the problem is histamine, so we are using the antihistamines. What you're thinking is, well, we've learned that cetirizine is 10 milligrams a day, and you're like, yes, you have. You can go all the way up as a primary care PA to 40 milligrams a day. You do 20 in the morning and 20 at night. Okay? And I would actually not do oral steroids for a kid because the rebound is much worse. So if you were going to do that, I would leave that for the allergist. This is one thing that the allergist hates because you know what they're going to do if they go to the allergist? They're going to do 40 milligrams of an antihistamine, avoiding triggers, and saying, I'm so sorry this is happening to you. Okay? So allergists are going to be doing the same thing that you are going to be doing. They're not going to be doing significant skin testing, or anything else. So chronic urticaria in an adult or a kid, something that the PCM can manage. Anaphylaxis. Anaphylaxis now, you have even deeper response to that true allergic IgE mediated, and you have to have how many systems? 2. So could it be any 2? Or does it have to be one of these plus something? It can be any 2. Yep, so you can have somebody who has nausea and diarrhea and hypotension. And that is an anaphylactic response if you have that inciting thing. If you have syncope and wheezing, you can have that. So any 2 systems that are involved when you have a triggering event, right? So this would not be like, I have a cold and I feel hypotensive and a little dizzy, I guess I'm anaphylactic, right? You have to have something that is causing this anaphylaxis, but you don't necessarily have to have respiratory or skin involved. You can have any of the 2 systems together. Your most common allergens that are going to cause that, we talked about this in block 1 with your foods, those LEAP trials, so peanuts are going to be one of those things. We want an early introduction to those highly allergenic foods. For kiddos, the number 1 is going to be your penicillin if they're going to have a true anaphylactic reaction. A lot of people are really, really allergic to those Hymenoptera, so wasps, yellow jackets, anything like that. That venom can be very, very triggering. But you really can be anaphylactic to anything in life as well. It's just a little less common than really for chronic urticaria. This is going to be a foot stomp of one of those things because this baffles me. To this day, I will never not be baffled by this. This is the one disease that we, as a community of providers, truly don't give the first line medication for. And I've never understood why, right? Because we preach this, you have anaphylaxis, we're going to give epi, right? And then we sit in the ER or we sit in an ambulance or we sit somewhere else and then we're like, well, what about some steroids? Well, what about some Benadryl? Well, maybe we could give this or that, I don't know, right? And then we portray that in movies too. If you think about Hitch was an anaphylactic. His face had swollen up and he couldn't breathe and he was going to drink the bottle of Benadryl. Drives me nuts, right? So this is the one thing that we preach that the first line is epinephrine, and yet we don't give it if we think that it's anaphylaxis. So I would encourage you as providers to really think, is this anaphylaxis? And if it is, why am I not giving the first line medication? Because that should be epinephrine. So epi that you are giving, 0.01 mg per kg. Use that Broslow tape. If you need to have that in an emergency type setting, you can give it IM, repeating as much as needed. Certainly if they continue to have refractory anaphylaxis, despite multiple times of giving this, they have left themselves in admission. Yes, you can give normal saline in to correct any volume. They have a distributive type shock. I should have asked you. That's a good question. Thank you. Should have put that on the test. You can do a beta agonist like albuterol if they have some wheezing to help open that up. We can give steroids. We can give diphenhydramine, like that. But the point is, your number 1 thing is going to be epi. I don't remember what I put on. Oh, because we'll have anaphylaxis plans too. So we had an asthma allergy or asthma action plan for kids that you have a known anaphylactic response, let's say to peanuts or shellfish. They will also have anaphylaxis plans for school or for sports as well too. Your difference here for kids, you have EpiPens. For adults, you have EpiPen juniors if you are under 30 kilos. So let's have a couple of things. Let's use our provider brains together. What if you are somewhere and the child is clearly like 15, 16 kilos and all you have is a regular EpiPen? What do?
Use it.
Use it, yep. Let's say the child is not 15 kilograms yet. What do? Use it. Yes, so the point is, if you need epi, give epi. The worst thing that happens with epi is what? They're tachycardic and they feel a little shaky, right? I had a friend in residency who was doing a training for the local CDC on base, said, I'm going to teach you how to do this. Went like that. It was an actual one, not a trainer, gave themselves a whole dose of epi. And so that day on shift, they were just a little jittery all day, right? So that's the worst case scenario. So I don't know, again, why we don't give that, and we're so hesitant to give epi for anaphylaxis. So you'll see this when you're out there, and you will think to yourself, huh, maybe she had a point. Avoiding what they can't have is obviously going to be key. And then something, just a little plug, I think we will see anaphylaxis change over the very short course when we are all going to be providing together. A couple of reasons why I think that. Number one, their new drug came out, Neffy, so it's an intranasal epinephrine, as opposed to something with a shot. Why is that happening? Well, people were very, very reluctant, again, even providers, to give this dose of epinephrine. People were much more okay giving it if there was something that they could just give in their dose. So that would be one big change that I think we will likely see over the course of time. Change two is the medication Xolair was just approved for desensitization for anaphylactic food ingestions. So it's a continuing area that is a hot topic for research. So this, what I'm saying today, this is what you all will be on your boards, will likely be very different in the next 5 to 10 years as you practice. Oh, I guess that's the end of that. A couple of last things for ortho. Okay, a little bit different, right? Do adults get fractures? Sure. Do children get fractures? Yes. All the time because it's an end and why? Yes. Can we break it up? No, somebody breaks it a little bit. Okay, so one of the things that is the problem, why is it such a problem with fractures in children? The growth plates, and that growth plate is really what we are worried about. So if you're looking at Salter-Harris fractures, that is a specific fracture type to a child that has that growth plate involved. So that is going to be the thing that we worry about the most. I have, for the life of me, I have had the hardest time with Salter-Harris and remembering what type is what. So maybe it's not as hard for you. But type 1 is when the growth plate is separated. So I usually think type 1, I can get one little finger in there between the growth plates. Okay? Type 2 is when it goes up into the metastasis. So type 2 is going up, or closer into the bone of metastasis. Type 3 is tri, so it's in that lower. Epi has 3 letters, so 3 for epi. I don't really know. That one's really hard for me for whatever reason. 4, it's going through, so I have my knife hand. I go through all of them. And then 5, I finally got it. It's rammed together. I just bumped myself. So maybe that's not helpful at all, and you have no problem with Salter-Harris. Kind of significant problem. There was my Salter-Harris story. So all of that to say, any of your Salter-Harris, you have an increased suspicion for there being some long-term consequences because your growth plate is involved. So most common fracture types that you see, you could see really any of them. You could see that they have a spiral fracture. What are you worried about for spiral fractures? Yeah, some kind of abuse. Was there a twisting motion for that at all? So something to think about there. Transverse, does it just go through? Oblique, is it on the line? And then multiple pieces, always a concern for that. We talk about green stick fractures because these happen not uncommonly in kids. This is happening when one side fails, but the other side does not. And this happens in kids a lot because they really are so pliable. So if you think about a green branch on a tree, it's a lot harder to break all the way through, and so that side where you're putting that tension on stays intact while the other side splits. Very similar process to what happens in a child's bone. So it does not cause a complete fracture, but it is tearing that cortex, so it is considered a fracture. So it's something that we do see in Peds worlds. Buckle fractures. Buckle fractures, it's truly when the bone buckles down. Right? The bone kind of crushes in on itself, but the growth plates are not involved. So this is going to require remodeling of the bone, but this should be handled at the PCM level. So a buckle fracture is something that we all can just handle together because there's nothing that you're going to do. They need to be immobilized in a splint for 4 weeks, but they do not need any kinds of surgeries or any kind of true casting, anything like that. An immobilization while their body remodels that is going to be good enough. So buccal fracture is one thing that you guys can keep internally in-house. A couple of things with scoliosis. So we see this was added to your boards recently, where you have one side of the rotation, so you have an increased hump on one side and not on the other, determined by your cod angle to determine how significant this is. So most of the time, it is idiopathic in nature. However, if you're thinking about this, think about what is happening. Remember, you have a little small child that is growing up into a transformer. That process doesn't always happen simultaneously. So you have some times where the muscles haven't caught up, where they are truly outgrowing their spine, and so you have this idiopathic adolescent scoliosis that is really from becoming an adolescent. And they will oftentimes outgrow this for that very reason, is they are finishing becoming an adult and they outgrow it because everything has caught up now. How does it do this? I don't know. Torticollis, we mentioned this at the beginning. Block one, so we're rounding this out here at the end. Come on, lower back, do it. Try to push through here till the end. But you have one side, so you guys all know, if you're filling out where your sternocleidomastoid muscle is, you can see it, you can feel it for yourself on both sides. If one of those gets shortened, what happens? One shortens, so now I have rotation and then flexion on that side. So now your baby's head is like this. What's going to happen right here on the head then when they're laying down? Yep, you end up with a flat spot, so plagiocephaly. So torticollis is one of the most common underlying reasons that you end up with a positional plagiocephaly. Back from block one. Oh, I didn't even put it on there. It's like, you guys are so smart. It's up there too. But you are. You're so smart. So this one revolves a lot of stretching of that affected side, PT, to make sure you have muscle balance of that. True worsening torticollis can result in some longer term things, goes with some syndromes. That's a little bit beyond what we're doing today. Last couple, you have the gymnast wrists. So this is that recurrent and repetitive pounding on the wrists. So our wrists were really not made to walk on. You see these little 8-year-old girls that spend a lot of time walking on their wrists or significant pounding from the tumbling on their wrists. So gymnasts are associated with this the most. And you're worried that so much weight bearing on that wrist is going to cause that premature closure of your growth plates and destruction of that growth plate. So they are not happy with you and you say, hey, I need you to absolutely rest and do no gymnastics for the next however long. Usually start with about 6 weeks. They are not happy with you whatsoever. Eventually as adults they are often much more happy when they have function of their wrists. Contrast this, the other one that we see commonly in children is a little league elbow, where you have compressive forces on one side and then the extensor on the other. So you end up with a continual elbow injury from doing this. So one of the things that we will recommend is that for young children that they are continually rotating positions. So that's not just to give everybody a chance to play all of the positions, that's truly to avoid these chronic, repetitive early injuries in kids from those recurrent repetitive tensile forces. So what you're seeing is one side is going to be completely stretched, one side is over and over going to be compressed, and over time that creates that chronic injury that you're not supposed to see in an 8-year-old. Osgood Slaughter, do you need to take a break or do you want me to push through? Push? Okay. I figured that, but you never know. Osgood Slaughter disease. So this is one of those common things that we see in adolescents with knee pain. And this is another one sort of like that adolescent scoliosis. A lot of times you're seeing that this is hurting them because it's functionally they are outgrowing their little legs. So a rapid period of growth causes a small avulsion fracture from the tibial tubercle as it's kind of pulling up as they're rapidly growing. And so that's why it can last for 1 or 2 years because they're continually using their legs, their knees, and yet they have this kind of partial avulsion fracture off of that tibial tubercle. So yes, you're going to do rest and modification of activities. You can use some pain control, some ice, but ultimately they kind of have to grow into their bodies, grow into their legs, and let that avulsion fracture heal over time. This one you can do an x-ray for, but it is much more common that you are going to make a clinical diagnosis because there is such pinpoint pain right over that tibial tubercle. So if they come in and they say, man, my knees have just been really hurting, and you have direct pressure over that tibial tubercle, and they feel like they're going to jump off the table, you have made that diagnosis clinically. You don't necessarily need any kind of other imaging from that. If you do get it, you will see that there's that teeny tiny little avulsion fracture as that tibial tubercle is lifting. This is another one that I think that we'll be seeing in different guidelines over time, but right now it is change in activity modification and pain control is necessary. My favorite one, nursemaid's elbow. So what is the typical scenario for a nursemaid's elbow? How do these kids come? Yep, they're swinging in between mom and dad, and they swing up, and the radius comes out of that annular ligament. So how do they usually come in holding their arm? Yep, they kind of come in like this, and they're totally fine. So they're using this one, they're doing whatever, and they're holding it like this. So if you're like, hey, do you want a sucker? And they will literally like move their whole bodies around to get the sucker with their other hands. Like they will not use this hand. So how do you fix this? Pop it back in. There's two ways to do that. How do you do that? A lot of this. Yep, so a couple ways to do it. You can either supinate and flex, or you can pronate and extend. You can do it either way, so people will get comfortable. My personal favorite is when you supinate, because you have put that aligned with the annular ligament and flex. You usually get one shot at it, and so you get everything prepared. I hold onto the elbow with one hand, and then I have a quick motion where you will supinate and flex in kind of that one motion, and that should pop it right back in. You should feel it pop. They should give a little bit of a scream, they're like, ah! And then they're completely fine after that. And then they're just back to being a little kid. If they're not back to doing that almost immediately, you probably didn't get it. So I have seen kids, they did that, and then they leave the ER like this, and they're like, oh, it's just going to take a little while. It should not take a little while. They should resume completely normal function almost immediately. So however you want to do it, either rotate and extend or supinate and flex. You don't need an image. Image won't tell you that something is out of alignment of the ligament. Anything else? Nope. Mom and dad, you guys already said that. Once it happens once, it's more likely to keep happening. So if they were swinging, and now you know that there's this ligament laxity, they say it's probably going to stay lax. It's probably not. The ligament was like, oh, I'm lax. I should tighten up. Okay, so if it happens once and you know the mechanism, try to avoid that. The other thing that you'll see this for is parents, if the kid is just trying to like cross the street, and they're just like, doo-doo, and so a parent does a quick jerk with one arm to keep them from crossing the street. That's usually the other mechanism you see. Two more, leg calf Perthes disease versus skiffy. So leg calf Perthes, something, for whatever reason, has gone awry, and you have avascular necrosis of that femoral head. So it usually fits a particular pattern of this child. So usually a young school-aged, skinny little boy. That's who this typically is. So 7, 8, 6, 9-year-old boy, skinny little thing who has a atraumatic lip. So there's nothing that we have. He doesn't really hurt, and he's just walking around with this limp. And so mom is like, why are you walking like that? So, I don't know. And you ask them, did you have a car accident? Did you get hit with a baseball? Did you fall in soccer? Did you fall out of a tree? Nope, nope, nope. So this atraumatic, painless limp in a young school-aged male is usually the sign for I need to get some x-rays. So if I'm getting this frog leg x-ray, what is the frog leg x-ray? How does it look? Yeah, you literally do this. So it is a 45-degree angle where you're trying to see the opening of that hip to have that look. Most of the time it is self-limited. They will go to ortho and do pain control. They will continue to monitor to make sure that blood flow is restored. But this is not something that needs a surgical intervention for the most time. And they usually have pretty good outcomes. Some osteoarthritis later on in life is seen of that. If you have this, the other way that I've seen this present is outside of a limp. They will come in with knee pain. So if they have knee pain, remember a joint above and below, so doing a good ankle exam and then a good hip exam can be super helpful for that. And then they will be fine with the frog leg. They will not want to internally rotate that hip, because that's where that femoral head is in that hurts. So we're looking at the necrosis of that femoral head on one side. It just kind of slowly starts to wither away there. Poor blood flow, watershed area. The thing we see it. Contrast this with SCFE, or split capital femoral epiphysis. So this one, much worse. So you're like, this sounds very similar, sort of, until it's not. So this one is a true emergency. So the other one, you're like, oh, that's kind of weird. Let's get some scans. Let's see how you're doing. Let's get you over to ortho. This is like a true, I think there's SCFE. This is an orthopedic emergency. Can be associated with a lot of different syndromes. So trisomy 21 is another one. Hypothyroid. So all the things that we've talked about in PEDS this whole time, they are going to be at higher risk for this. But the thing that should stick in your mind is a little bit older, obese male child. So they're both going to be male, but your age predilection is a little different, and the overall body habitus is a little different. I will say the majority of SCFEs I've seen have actually been little girls, so that's really not helpful, but for your board purposes and test purposes, they will be your standard classic patient. So just always remember that patients don't read the textbook, so they didn't get the memo that they don't follow that classic pattern. However, learning that classic pattern helps you to at least be able to handle that. So a little bit older, the mean average is about 12, so these pre-pubertal, obese little boys can start lateral or unilateral, progress to bilateral, and you really worry that they are not going to be stable, that this is really kind of literally slipping off. So it can present as knee pain, can present as hip pain, can present as a painful limp. There's a lot of ways that this can be. Again, this is that hip joint is what hurts, so that internal rotation is what they have a whole lot of issues with. Same frog leg that you're going to be getting to be able to see that. If you're like, this is a SCFE, I know it's a SCFE, absolutely it is, you can get the cross table lateral as well. For your purposes, just know the frog leg view. Okay? That's what I need you guys to know. And when you are looking at this, classically they will teach, and you probably learned in ortho if you have this at all, it's like the ice cream falling off the cone. You're like, well, really it's the cone falling off the ice cream. So if you're really looking at the x-rays, we'll take a look at that. The cone is what is slipping. The ice cream is not falling. So that is really what's happening with this. You're looking at this by how much displacement, so how much is that cone coming off of the head of the ice cream, or the femoral head. And so you're doing that by percentages. So is it more than 50% slip? Is it less than? So on and so forth. So if you're looking at this, you have the normal side, the ice cream cone is on that, on the top, the femoral head is in place. If you're looking over there, the femoral head is still in place, but you have slipping of the ice cream cone, the rest of the femur. So that is what's going on with SCFE. How do you treat this then? Immediately make the patient non-weight bearing. So I don't care if they walked in, if they ran in, if they were totally fine. If you have a diagnosis of SCFE, the first thing you do is get them to be non-weight bearing. So that is absolutely first. Make them non-weight bearing. The next thing you will do, this would be like one to stop clinic. So I'm bebopping along. This isn't the one that I can call at the end of the day. Once you have a known SCFE, you will call ortho and you will say, hello ortho, I have a confirmed SCFE. Would you like to see them now, or would you like to see them in 20 minutes? Up to you, right? That is the emergent nature of this consult. And then eventually, obviously, they will go and surgerize this to be able to hold it in place to help prevent avascular necrosis of that femoral head and any kind of other cartilage breakdown. Limping child has a log differential. There's some totally fine things, there's some not. So this is a little bit more phase 2 when you get to your PEDS rotation. Told you that was quick, and you guys have finished PEDS. I know that there's no air conditioning, but I don't know, we can figure out if or when we want to do a review. We can figure that out. Happy to do that tomorrow, whenever. I'm so proud of you guys. You guys did such a good job. Questions, comments, concerns, anxieties, frustrations, griefs, miscellaneous toxicities. You guys all know my phone number, so text me if you need anything. Otherwise, I'll figure out a review, and then I'll see you Monday morning for the conclusion. Pediatrics.